We look forward to listening to your presentation.
Thanks, Grigori. Thank you, everyone, for having me. My name is Kωνσταντίνου. I work at the Essex Cardiothoracic Center, and I'm going to speak about assessment of coronary endothelial function and spasm provocation. We have set up a regional INOCA service in our center in Essex. It's at its very early stages. But what we do is we receive referrals of patients who've already had an invasive coronary angiogram or CT coronary angiogram and have unobstructed coronaries, but persisting chest pain. We review them in a clinic, and then we list them for an invasive microvascular function assessment. So what our microvascular function assessment includes is initially an RFR to make sure there is no epicardial flow limitation. Then we do the Bolus thermodilution, as explained earlier, and obtain CFR and IMR. We measure absolute coronary flow at rest and hyperemia, as shown by Daniel earlier, as well as absolute microvascular resistance. And then we go on to perform endothelial assessment testing by administering acetylcholine, either as an infusion or as a bolus, or both. And I'm just going to speak to you a bit more about that. So we test epicardial function first, then we do bolus thermodilution to test a non-endothelial dependent microvascular function, and finally we do test the endothelium and test for vasospasm at the end. So how acetylcholine should work when administered as a slow infusion in a coronary artery, it should bind to the endothelium receptors, causing an influx of calcium into the cells, activating NOS, which converts L-arginine to nitric oxide, which then activates SGC that converts GTAP to cyclic GMP, causing smooth muscle relaxation. So a slow infusion of acetylcholine in a coronary artery should cause smooth muscle relaxation and should increase coronary flow if you've got a normal endothelial function. So how do we do the procedure? We use 6 French guides, and generally we perform the assessment in the LAD, unless there's a reason not to do it. For example, we've had a couple of occasions of elderly patients with a lot of tortuosity in the LAD, making it difficult for a pressure wire to go down. In those cases, you can interrogate the circumflex, and less commonly, you can interrogate the right coronary artery if you can't put a pressure wire down the left system, or if everything in the left system is normal and you still have a very high level of suspicion of some abnormality. But generally, in, I would say, 99% of the cases, we interrogate the LAD. We need to use a pressure wire X and pass it to the distal third of the artery. We need the ray flow catheter and an infusion pump. The ray flow catheter should sit in the proximal LAD, not in the left main, and not too far down the LAD where you might miss diagonals and septals coming off. And of course, we need to administer acetylcholine and use the Corventis software to analyze the results. We have to be careful about making sure our patients stop taking the vasoactive drugs for at least 48 hours before coming in. And we don't administer any vasodilators, so we don't give a radial cocktail or verapamil, and we don't give nitrate during the assessment. So pressure wire X is passed to the distal LAD. We always measure RFR first to make sure that there's no epicardial limitation. Often the coronary artery is not entirely normal. There might be mild diffuse disease, so we need to make sure RFR is not ischemic. And then we pass a pressure wire to the distal third of the artery and a ray flow to the proximal LAD. And initially we do saline infusions, as Danielle has shown. We inject saline at 10 mL per minute and then at 20 mL per minute, and that way we get resting and hyperemic flow. And then we go on to give the acetylcholine infusions. We do need resting and hyperemic. We need resting flow more than anything, because our acetylcholine flow will have to be compared to the resting flow to check how it's changed. Finally, if everything is normal, when we've done the bolus thermodilution, which I've not shown in this algorithm, and acetylcholine testing, then we give boluses of acetylcholine to check for spasm. We're finding out that in most of the patients, acetylcholine infusion is sufficient to propagate spasm. So it's not very commonly that we need to give the bolus at the end. So patients who are going to get spasm tend to get it with the acetylcholine infusion before we even have to administer boluses. This is a snapshot of what we get from Corventis. So this is a measurement of resting and hyperemic flow. That's flow at rest with the infusion running at 10 mL per minute. 10 mL is not sufficient to cause hyperemia. So we get resting flow from the 10 mL infusion. And then we increase the rate to 20 mL per minute. 20 mL per minute causes hyperemia, so we've got hyperemic flow. This way we can also calculate CFR by continuous thermodilution. So we've got CFR from the bolus thermodilution, but we also get CFR from continuous thermodilution by doing this. And then we administer acetylcholine. So this is as a Corventis screen recording taken during acetylcholine infusion. It looks very similar to the saline Corventis screen. So we give a slow acetylcholine infusion and measure the mixing temperature, then pull the pressure wire back and get the temperature at the tip of the ray flow. That way we can measure acetylcholine flow. Now, when we compare acetylcholine flow to resting coronary flow, we get acetylcholine flow reserve, and that should be greater than 1.5. So flow with acetylcholine should increase 50% from baseline flow. If that doesn't happen, then patients are very likely to have endothelial-dependent microvascular dysfunction. And then with the bolus acetylcholine administration, then diagnosis of vasospasm is mainly an angiographic one. There's no measurement that we do physiology-wise. But following administration of an acetylcholine bolus, you wait for a minute, do an angiogram. If there's more than 90% angiographic spasm and the patient has chest pain and or ischemic ECG changes, you need at least 2 out of the 3, then you can diagnose the patient with coronary vasospasm. And I've got a few examples here. So this is someone who's got a normal endothelial-dependent function. We can see on the left, the resting coronary flow is 0.044 liters per minute. With acetylcholine infusion, it increases to 0.078 liters per minute. So that's an increase of more than 50%. So this patient has a normal endothelial-dependent function. Then we've got someone here with endothelial-dependent microvascular dysfunction. We can see that the resting flow again is 0.044. And then with acetylcholine, there's barely any increase. So we've gone from 0.044 to 0.05. So they're very similar. There's no increase of more than 50%. And as you can see, the FFR here is also low. It's gone below 0.8. So this patient also developed epicardial spasm during the acetylcholine infusion. So she appeared to have both endothelial-dependent microvascular dysfunction and vasospasm. And this was her angiogram. We took this angiogram at the end of the acetylcholine infusion and after we stopped measuring flow. On the left is the angiogram before acetylcholine. On the right, you can see that there's near complete occlusion of the LAD. Patient had chest pain and some anterior resting depression. And that's me done. Thank you.
Thank you very much, Cleo. That was a very interesting talk. Any questions? Foti? Dr. Kolokathis? And then Dr. Xenogiannis.
Excellent talk. I have a question. According to your experience, could you wait could we wait any severe adverse effect during the acetylcholine infusion? And what do you suggest to face this?
Thank you. Thanks for the question. Initially, when we started doing this and we were looking at protocols from other hospitals, there's always the suggestion to put in a temporary wire before you give any acetylcholine, put on defibrillator pads. We did consider all of this, but the infusion tends to be safer than the bolus. So we started doing the infusions without putting any temporary wires up front or defib pads on. The infusions tend to be very well tolerated, and even when, I mean, you have to hold your nerve when you can see the FFR go down to 0.70, the patient has ST elevation, ST depression, and chest pain. So you can see there is probably some spasm, but we've never had to stop the infusion. We can always complete the 2 minutes of administration. We've not seen any heart blocks with the infusion. People do get to go bradycardic with the bolus, but the infusion seems to be very safe. So we've not had any adverse events. We've not had to stop the infusion. Even with very severe spasm angiographically, people seem to tolerate that well, and it all resolves after administration of intracoronary nitrate. I used to initially keep a cyan blue wire down the artery just in case it closes off and we can't get access to it. But the most recent cases we've done without a safety wire down, and nothing's gone wrong yet. So
thank you.
Thanks.
Dr. Xenogiannis? So actually, Cleo, you haven't seen any serious adverse
We haven't
event,
had any, no.
Dr. Xaplander?
Thank you for this beautiful talk. I just have a question. What do you feel about manipulating the artery before testing for spasm with a wire that can be irritative in itself?
Yeah, thanks for the question. A difficult one. I'm noticing that most of the patients don't have normal coronary arteries, normal LADs. There's often tortuosity. There's often diffuse mild disease. I've not noticed significant spasm after passing the wire down. We've not had that yet. And we always do an RFR. It's the first thing we do. We've not had a low RFR yet. I guess if we had a low RFR, we'd have to stop and we wouldn't carry on to do anything else. We might consider giving the nitrate to prove whether spasm resolves, but we've not had to do that yet with any of the cases.
Any other question? Dr. Milkas?
Yes, finally, there are a lot of questions about the procedure. And finally, do you prefer radial access or femoral access? Because I can remember back in the past that we had several cases with radial spasm that we couldn't take out the catheter. What is your experience on this?
So I think we should take advantage of Cleo, that's his experience on technique, and ask all the questions and see how we're going to do it here in Greece too.
We don't use femoral access, so we go radial or distal radial. Generally, I don't give anything in the radial artery, even when I do PCI. I give sedation IV, intravenous diazepam, but I don't use a radial cocktail. And I stopped using a radial cocktail after, when I did a fellowship after finishing my training, and no one used a cocktail where I did my fellowship, and realized that during my training, I worked with people that used a variety of cocktails, a combination of verapamil and nitrate, or just one or the other. And then I worked somewhere where no one used anything. So I don't use anything. I make sure they are relaxed and sedated. And we can complete the procedure radially in all of them.
You have experienced no radial spasm during the acetylcholine infusion so far?
No. But then I guess even if they had it, because we're not manipulating the catheter at that point, we probably wouldn't notice it so much. And it would probably resolve after we give the GTN intracoronary. So no, we've not had trouble removing any of the guides.
And if you agree, some of the protocols I know allow 2.5 verapamil, right, intraarterial. So you can, if you run into problems, I guess you can give verapamil either the way up or the way down, right? I think this would be acceptable in most protocols. I don't know in your center.
Yeah, I'm sure it would be. We tend not to give it, but we had a patient the other week. Normally we try and stop all medications before they come in for at least 2 days. But when we stopped this lady's verapamil, then she developed bigeminy. So when she came in, we couldn't do the assessment because she had ventricular bigeminy. So we had to bring her back on the verapamil and did the assessment on the verapamil, and it was still very abnormal. So I'm sure you can give a small dose of something if you have to. If someone has a significant, at least, abnormality, you still see it.
Dr. Varlamos.
Great talk. Thank you very much for your experience sharing with us. We don't do acetylcholine in our cath lab, and I would like to ask or a difficult question or a wrong question, so excuse me. Sometimes we experience spasm with mechanical reasons or about the patient some clinical factors. Is any correlation or association with what you're doing? We can treat this. We say no pericardial vessel disease, but we have spasm. Nitrates, it was good for our patient. We can give calcium with this specific technique. Sorry, thank you.
Thank you. Do you mean that you get epicardial spasm? We've all seen it during angiograms or PCIs, haven't we? Yeah. Well, I think if you see spontaneous spasm, that it is very, very likely that they would get spasm with acetylcholine if they can get it spontaneously or with manipulation of the coronary engagement of the guide or putting a wire down. So if we saw spontaneous spasm, we'd probably feel that it's not necessary to go ahead and give the boluses of acetylcholine. But I'm not sure anyone has tested these patients in a study to see whether they actually do and develop spasm with acetylcholine. But you would probably be nervous to give a bolus of acetylcholine in someone who's got spontaneous spasm anyway. If your patient has symptoms and you don't have another explanation for the symptoms and they sound symptoms consistent with spasm, so chest pain at rest that comes and goes, then yes, you can consider treating it.
Dr. Sacalidis, you have the last question.
Yes. Great talk. Congrats. I would like to ask about microvascular spasm. In cases of patients without epicardial spasm, that they have symptoms, that they have changes in ECG. It is a proportion of INOCA patients, we know, but it's very difficult to diagnose. How often do you face it, and what's your opinion on that?
Thank you. Very, very good question. And I mean, when you think of everything together, it does become very confusing. So there's endothelial and non-endothelial function, and then there's epicardial and microvascular spasm, and you could have one of these abnormalities, or what we're finding out is that patients often have more than one of these abnormalities occurring together. So we diagnose endothelial dependent dysfunction based on flow and how it changes with acetylcholine. If during acetylcholine administration, the patient gets chest pain and ECG changes and there is no epicardial spasm on the angiogram, then we tend to believe that they probably also have microvascular spasm.
Cleo, thank you very much for sharing your experience.
Thank you.
I think that was a great session. I want